Welcome everyone, and thank you for joining us today at our first Critical Conversation Lunch and Learn on Health, Equity, and Justice, hosted by the College of Health and Human Development at Cal State Fullerton. My name is Lisa Lopez. I'm the Senior Research Development Officer in the College of Health and Human Development, and today I will be your host and your moderator for the Lunch and Learn. Before we get started, I want to mention a few things. First, we are recording this Lunch and Learn to post online in a few days for those who cannot join us today. Right now, everyone is muted, but we can see your video if you choose to turn it on. At any time, please go ahead and use the chat function at the bottom of the Zoom window to send me, your host, questions for Dr. Sami. I'll be compiling all the questions, and later on, we'll be having an open discussion so everyone can contribute to the conversation. We have a rather large group, as you can see, joining us today, but we really want to encourage participation. So if you would like to make a comment or ask a question directly to Dr. Sami, please use the raise hand feature found in the participant window. And during the open discussion, you'll be unmuted for everyone to hear. One last thing before we get started, you'll quickly notice there are no slides for today's discussion. These days, we all have a lot of Zoom meetings, so we wanted to make this Lunch and Learn different and not a typical lecture. But instead, we wanted to invite you into a conversation with Dr. Sami. We'll start this conversation after Dr. Sami concludes her remarks. So let's get started. Let me go ahead and admit those that haven't gotten in yet. One sec. Today, I'm very happy to introduce our presenter, Dr. Mojgan Sami, Assistant Professor in the Department of Public Health. Dr. Sami teaches courses on global health and cultural competence. She's an interdisciplinary scholar currently focusing on health equity as an outcome of the ways we design and build our infrastructure. She's the Vice President of the Board of Directors of California Walks, a mobility justice organization. Prior to her academic career, Dr. Sami worked at the World Health Organization and the World Bank. After leaving the World Health Organization, she was appointed as an advisory member to their Health and Environment Committee in the Special Program for Research and Training in Tropical Diseases. Currently, Dr. Sami serves as the only American appointed to a global working group for planetary health with the International Union for Health Promotion and Education. And with that, I'll let the remaining folks in, and I'll turn it over to Dr. Sami.
Thank you, Dr. Lopez. Thank you to all of you who are joining this conversation. A special thanks to Dean Rhodes and the College of Health and Human Development for inviting me to be the inaugural speaker for this series. I'm not an MD or a clinical infectious disease researcher. I study pandemics from the perspective of an interdisciplinary scholar, drawing from urban planning, public health, public policy, climate change, and critical studies. So my remarks today are a reflection on some of the questions emerging in my own scholarship, which has been impacted by the dual pandemics of COVID-19 and systemic racism. My focus is on understanding the root causes of disease and injury, which are situated outside of change behavior models and doctors' clinics. I am interested in understanding the systems that create the context and conditions from which individual and community health emerge. These are grounded in historical contexts. They are situated in social, political, economic, environmental, and infrastructural systems of our planet, all of which are influenced by the ways that we think about human nature and social reality, our conceptual frameworks. I hypothesize that these conceptual frameworks, a term I use to reflect our ontological and epistemological assumptions, form the foundation of the ways that we socially and physically construct our world. In other words, our conceptual frameworks not only have the power to frame our research questions and our hypotheses, but they have a direct influence on the ways that we understand, design, and manage the problems of our world. In a way, I study the diseases of the body politique, such as ecological destruction, war, racism, inequality, injustice, and inequity on health outcomes. Collectively, these social diseases are part of the structural determinants of health. And indeed, the study of pandemics in history is a study of the structural determinants of health. Today, we are collectively experiencing the deepest and perhaps most fatal challenge to the 600-year-old conceptual framework that socially and physically constructed systems to justify colonial occupation and exploitation of Black and brown bodies and land. COVID-19 has shaken the modern world out of its collective slumber and forced us to grapple with the taken for granted assumptions that we have about health, environment, disease, race, democracy, freedom, the role of governments, the economy, and human nature. It's forced us to interrogate our histories and ask a fundamental question that rarely gets asked at a collective level at the same time all over the world. What kind of world do we want to live in? Listening to the granddaughter of Dr. Martin Luther King Jr. a few weeks ago on the 57th anniversary of the March on Washington, I was reminded that Dr. King predicted this phase of the struggle in the civil rights movement in the 60s. He said the struggle for Black Americans would not end with civil rights. He predicted a continued struggle until genuine equality is achieved. And here we are, with a world that is at various stages of awakening in the middle of a pandemic, with an ecological disaster, challenging long-held faulty assumptions about racial superiority and what it means to be human. Collectively waking up, as we have seen, hasn't been easy. The process of awakening can cause anxiety and violence in communities who confuse equality with oppression because they are unaccustomed to thinking of themselves as equal. Incidentally, on the heels of Dr. King's assassination in 1968, the United States was dealing with an emerging H3N2 influenza epidemic that led to 100,000 American deaths. Health as a concept is so ubiquitous in public discourse that we may mistakenly believe we know exactly what it is and that all of us understand it and experience it the same way. But what is it? What is health? There are numerous academic and biological and medical definitions of health, including the often used World Health Organization definition that health is more than an absence of disease and is the state of complete physical, mental, and social well-being. But what does that mean? In the light of a pandemic, what is complete physical health? In the light of systemic injustice, what is complete social well-being? The dominant American discourses of health tend to blame disease and injury on individuals and define health through this narrow focus of biomedicine, somehow expecting our doctors and nurses and hospitals and pharmaceutical companies to save humanity from ourselves. Such dominant discourses of health tend to confuse health care with health and prevent us from doing the deep work needed to address the root causes of disease and injury, which go beyond biomedical and behavioral models. In public health, we remind students that doctors treat diseases in individuals, and our job is to prevent disease at the population level. So our focus in public health is always broader and has to include the structural determinants of health. So a healthy society is one that understands that both population health and medicine are needed in order not just to survive, but to thrive. 30 years ago, public health researcher Arlene Geronimus studied the experience of racism on the body and found that racial inequalities not explained by poverty existed across a range of biological systems. She actually called the health outcomes caused by racism weathering. This is much more than a metaphor. Multiple studies show the experience of racism and discrimination in communities of color causes increases in cortisol levels, the stress hormone, that accumulate over a lifetime. And with recent biomedical findings that increases in cortisol can complicate COVID-19 recovery, systemic racism itself becomes a social vector for health disparities. So in this time of dual pandemics, of COVID-19 and racism, how are we individually, collectively, institutionally conceptualizing health? What are the assumptions we are making about the responsibility of being healthy? Who is accountable for our health? Who is responsible for community transmission of infectious disease? Who is indeed accountable for the preventable deaths caused by COVID-19? Dr. Martin Luther King Jr. at a meeting in 1966 on hospital segregation said of all the forms of inequality, injustice in health is the most shocking and most inhuman because it often results in physical death. Injustice is the root cause of mortality and morbidity, particularly for Black, Indigenous, and people of color. So when I see the census race ethnicity categories used as a variable in health research, I keep asking myself, what is this variable helping us to understand? The concepts of race, ethnicity, nationality, and culture are not the same, yet they're conflated in the census race ethnicity categories. And research that uses this variable often doesn't interrogate the assumptions behind it. We must know by now that the race categories originated as a social construction formulated by European colonizers and traders of enslaved Africans who had to justify their cognitive dissonance for the violent occupation of indigenous lands and the enslaving of Black people for labor exploitation. There is no race DNA. The amount of melanin in our skin depends solely on our historic proximity to the equator. The categorization of human beings into racial hierarchies is completely socially constructed to privilege the melanin levels of European colonizers who were far away from the equator. Historically, the only groups that have remained white in the US Census since 1790 are white colonial elite descendants from Britain. Studies on racial health disparities consistently find the same conclusion. Communities of color suffer disproportionately from higher levels of mortality and morbidity in all disease categories, including COVID-19. I keep asking myself, how many more studies do we need to confirm the hypothesis that systemic injustice and racism are the root causes of health disparities? So recently, health and medical scholars started calling for disaggregation of race data to understand the disparities within census categories as a call for health equity. So Dr. Hayes Bautista from UCLA disaggregates Hispanic Latinx data into national sub-identities, Mexican, Cuban, and Guatemalan, for example. But does that give us the nuance to understand the health disparities between South Americans of indigenous descent and those of Spanish or Portuguese colonial descent, and those whose ancestors were enslaved Africans? Dr. Bridget Blebu from UC San Francisco disaggregates Black population data in the US by comparing health outcomes of recent African immigrants to those of the descendants of enslaved Africans born in the US. Her research finds that recent immigrants from Africa have health indicators on par with the white population. And then descendants of enslaved Africans born in the US have consistently lower health indicators. And she finds that health indicators of African immigrants in the US erode over time, pointing to further evidence that anti-Black racism is a root cause of disease and injury. A hypothesis that was earlier confirmed by Dr. Joy DeGruy in her important and seminal work on post-traumatic slave syndrome. And there are hidden populations throughout the census race ethnicity categories. So for example, South Asians are included in the Asian Pacific Islander category. Middle Eastern communities are hidden in the white census category. Asian is not a culture. Neither are any of the other census categories. There are Chinese and Japanese and Indonesian and Filipino and Korean cultures. And there are sub-ethnicities with unique practices within those cultural groupings. This homogenization of all nationalities and ethnicities from a geographic region through the colonial gaze erases the diversity and richness of culture and doesn't allow us to understand the unique health disparities hidden in these populations, nor does it allow us to actually develop appropriate, culturally competent health promotion and disease prevention programs. The 15th century European colonial conceptualizations of race, ethnicity, nationality, and culture continue to form the foundational assumptions behind the census race ethnicity categories. They are insufficient to understand the richness, diversity, and complexity of our shared human identity. The census has been revised since its first collection in 1790. For example, Native Americans were excluded for decades, but they're now included. Yet without the nuanced understanding of the diversity that exists in the hundreds of nations, languages, histories, and cultures that make up the original people of this land and the US colonies. Mexicans were considered white in the census some years and Hispanic in other years. Japanese Americans went to court to argue, if you're just basing this on melanin, aren't we white? Today, the race variable in health research helps us understand the level of injustice that exists based on physical characteristics. But doesn't it also perpetuate a false racial hierarchy that needs to be eradicated? This variable can tell us a lot about the ways that the colonial culture of white supremacy still defines the systems of our world, including our health and social science research. So I keep wondering, what would this variable be if we as a collective scholarly community came together in a cross-disciplinary, multidisciplinary context to redefine this variable with justice and equity as their foundational construct rather than white supremacy? I have to say I spend a lot of time critiquing the census race categories, and they are flawed, and we do need to grapple with it and change it, but I'm gonna need you to finish the census. Please complete it before the month is over. It's still important. We know that communities of color, particularly Black, Indigenous, Pacific Islander, and Hispanic Latinx communities, are suffering disproportionately higher levels of COVID-19 mortality and morbidity. We know that. Biomedical studies conclude that individuals with comorbidities, such as obesity, diabetes, and other chronic conditions, are more susceptible to COVID-19, and therefore are more likely to experience a severe case of illness and more likely to die as a result. Environmental health studies from around the world find that higher levels of air pollution also increase the likelihood of COVID-19 transmission and death. Public health studies continue to show that communities of color who tend to work in essential services, thereby increasing their risk of community transmission, they tend to live in multifamily households, which make it difficult for physical distancing in case of transmission and need of quarantine. They experience environmental justice, lack of affordable housing, lack of food access, lack of healthcare, the lack of the ability to rest, transportation inequity, and income inequality. But why are these indicators consistently worse for communities of color? My friend and colleague at Harvard, Dr. Thomas Punya, says one of the reasons is that we don't study social comorbidities as much as we study individual comorbidities. And in order to understand health outcomes, we need to understand the social comorbidities of systemic racism, misogyny, and discrimination. Pandemics such as COVID-19 do not suddenly cause inequities and injustices. Instead, they exacerbate and lay bare the existing deficiencies in the structures of society that prevent genuine equality, justice, equity, and healing. Consequently, it's not surprising that throughout history, pandemics are tied to dramatic social upheaval, especially when neither the scientists nor the people in power understand the nature of that contagion, be it a biological, social, or spiritual pathogen. For example, we know that the Antonine Plague, or the Plague of Galen, struck the Roman Empire in 2 waves in the 2nd century. Believed to be either smallpox or measles, it was spread by soldiers returning from war, as have many pandemics in ancient history. The plague quickly spread throughout the Roman Empire, which was at its height at the time. Historians estimate 5 million people lost their lives and analyze the Plague of Galen as the starting point of the empire's decline. Similarly, the Justinian Plague of the 6th century, believed to be the deadliest and earliest wave of the bubonic plague, ravaged the Byzantine Empire at its height and also marked the beginning of its decline. The Justinian Plague is estimated to have killed 100 million people. The Black Plague in Europe in the 14th century, which was one of the last waves of the bubonic plague, is tied to the fall of the feudal system and the subsequent rise of the nation-state system. It is estimated that 1/3 of the global population died as a result of the Black Plague. The nation-state system, emerging from the aftermath of the plague, led to the rise of European empire building, imperialism, Atlantic slave trade, ecological destruction, and the social construction of racism and racial hierarchy that continues to plague us today. In a way, the Black Death 600 years ago was the impetus for the conceptual framework that socially and physically created the systems, structures, and relationships that manage our world today. This is what COVID-19 is collectively awakening us to. The realization that the conceptualizations of the 14th and 15th century are not meeting the needs and exigencies of a global community that is yearning for genuine equality and justice. Furthermore, Europeans in the 14th and 15th centuries were highly superstitious and distrustful of the advances in science and medicine, particularly from the Islamic world, which had already outlined a sound understanding of germ theory by the 11th century. The European and American scientists would not completely embrace this theory until the 19th century. In fact, only after numerous yellow fever, cholera, and typhus epidemics struck cities such as London, New York, and Philadelphia in the 18th century. The lack of scientific understanding in Western society, coupled with superstitious beliefs, led to the spread of conspiracy theories and discrimination against the other, which included foreign merchants and the Jewish community, who were often scapegoated as the cause of disease throughout history. The racist and discriminatory narratives blaming COVID-19 on a specific race and ethnicity today is reminiscent of that age of ignorance and superstition in Europe 600 years ago. Around the same time that the Spanish colonizers arrived on the shores of Turtle Island, where they brought with them a scourge of epidemics and diseases which indigenous communities had no immunity to. Through both intentional and unintentional spreading of infectious disease, such as smallpox, 90% of indigenous communities were wiped out by European colonial conquests and settlers, who were then able to occupy land and destroy empires, such as the Aztec Empire. In fact, before Spanish colonial destruction of Tenochtitlan, the capital of the Aztec Empire, the site of modern-day Mexico City, indigenous communities lived on average 16 years longer than the average European. Today, that life expectancy statistic is completely flipped. The Aztec Empire was known for its advanced engineering and urban planning. The Aztecs separated potable water from wastewater at least 500 years before Europeans understood the links between waterborne pathogen and disease. But those advances and expertise were erased by colonizers who had to perpetuate a myth of superiority in order to justify their conquest and destruction of indigenous communities. In fact, this erasure of indigenous knowledge systems, which extended to erasure of African, Asian, and Islamic ontologies and epistemologies, is called epistemic violence by critical scholars. I wonder, what would health and well-being, how would they be conceptualized today if we had honored and included Africana, Islamic, and indigenous systems of knowledge into the modern scientific discourses. Pandemics, epidemics, and infectious disease outbreaks tend to force us into a collective existential crisis. Nothing like a disease that is not fully understood by science, those in positions of power, and the general public can bring the world to its knees and show us the existing deficiencies in the social, political, and economic systems that manage our world. Nothing can provide us with the humility needed to understand the limits of military strength and the scientific and technical advances than a novel virus. And nothing can bring to light humanity's collective state of moral depravity as reactions to calls for solidarity and unity in disease mitigation for COVID-19 and the eradication of racism. In fact, the dual pandemics of coronavirus and racism are indicative of a pattern of biological and social interactions that repeat throughout history, always signaling a challenge to our outdated conceptual frameworks, both for science and systems of governance. Thinking about the global experience of COVID-19, it's clear that in 2020, it's not the science that's failing us. That is a matter of time. Our failures lie in the ability or inability to challenge the outdated assumptions of health, race, democracy, our inability to recognize the collective human identity, and the refusal by some countries to stand with each other in collective solidarity to address COVID-19 and systemic inequality. In fact, countries that have achieved success in mitigating high rates of COVID-19 transmission and reopening their economies safely understood that both science and solidarity are needed for success. Our conceptual frameworks, the decisions we make, the ways we investigate, the ways we describe our world impact the ways we organize ourselves, the decisions we make, the resources we allocate, the priorities we set, and the presidents we elect. As such, we have to challenge our outdated conceptual frameworks and align them with the exigencies of this day and age, which is calling out for genuine equality, equity, justice, and healing. As Arundhati Roy wrote in April 2020, pandemics have forced humans to break with the past and imagine their world anew. This one is no different. It is a portal, a gateway between one world and the next. We can choose to walk through it, dragging the carcasses of our prejudice and hatred, our avarice, our data banks and dead ideas, our dead rivers and smoky skies behind us. Or we can walk through lightly with little luggage, ready to imagine a new world and ready to fight for it. I look forward to this reimagining with you in our conversation. And I would be remiss if, as a public health professor, I didn't remind you that in light of the lack of a national coordinated strategy for suppressing COVID-19 transmission, please continue to wear your mask in public. Practice physical distancing with anyone not in your household. Wash your hands, which you should have been doing all along. Stand as allies with our Black brothers and sisters until genuine equality is achieved. Complete that flawed census and vote early. Thank you so much. I look forward to the conversation. Thank you so much.
Thank you, Mo. Thank you so much. We want to give everybody some time to digest all of that, and definitely put your questions in the chat box. Or if you want to, we're about ready to start discussion. You can go ahead and raise your hand using the raise hand feature that's in the participant window. So I know we will give everyone just a few seconds. Right now, we don't have any questions. I think that was a lot of information, but it was great information. Thank you, Mo.
Of course, and please don't think you have to ask a question. I would love
yes,
a
comments
conversation. I would love a conversation as well. You know, one of the things I was thinking was, how do we engage in a conversation, a collective conversation about challenging those assumptions of the race variable? I feel like we need a collective, cross-disciplinary, interdisciplinary conversation about how that would look. How can we actually formulate a new variable? That's something that constantly weighs on me as I think about research from a social justice and equity perspective.
Does anybody have any comments, questions for Dr. Sami? Yes, we have one. We'll go ahead and ask you to unmute.
Hi, Dr. Sami. This is Pam McLaren. Good seeing you. It's been a while.
Good seeing you.
My thing that has come over and ever since we've had this pandemic is how little as a society we've changed from the 1918 Spanish flu. We had people then who didn't want to wear a mask, them that thought that if we just closed our borders, it would solve everything, and it really truly didn't. What's our steps that we should be taking that we're not taking right now?
I think that we often place the burden of mitigating infectious disease on the individual and forget that we have to employ institutional frameworks in order to get this done. And I think that's part of our challenge in the United States. We overly focus on the role of the individual and put pressure for individuals to have responsibility for everything, and forget that we have to also reach out and think about how communities can engage and how institutions need to be engaged. So I would say part of our work is reminding ourselves that it's not just about individuals in mitigation of infectious disease. It's about how do we reinstate the public health arm and allow public health to do our job. Do you know how disheartening it is to hear in this day and age that public health practitioners get their lives threatened because they ask people to wear masks? So I feel like we need kind of a reimagining of the values that guide us in the United States. We can't just be all about the individual. Individual freedom is great, but without responsibility and institutional accountability, it doesn't get us very far. So that's how I would respond to that.
Okay. Thank you, Nancy.
Thank you. Thank you, Pam.
Hey, Dr. Sami. So I think one great talk, and it was really nice to hear some thoughts on this. I think one thing for how we go forward is kind of understanding with epidemiology and causal inference framework, we tend to have that exposure variable, and it has to be something that is modifiable, something that we can actually change. And so there was a recent paper by JAMA on racial ethnic variation and nasal gene expression of transmembrane serine protease 2. I'm not sure if you saw it, but if you want to touch on that. But it's interesting and frustrating at the same time to see a paper like this still come out, utilizing a gene as a non-modifiable variable, and actually I don't know if they even had genes, but we're saying that Black individuals were at higher risk of COVID infection because of this gene compared to those who don't have that gene, whereas we're not actually addressing the underlying issues of why Black and ethnic minority groups are at higher risk of COVID, as you mentioned in your talk.
I appreciate the question. I wish I was a geneticist. Dr. Lopez is. Dr. Lopez, do you have a thought on that? She's like, no, don't talk to me.
No, this is your talk.
Actually, I wonder if Dr. Archana, of my colleague, or any members of my wonderful Department of Public Health, who are much more likely to answer your question, Ryan. I haven't seen the article, but I'm wondering if any of the epidemiologists would comment on that as we go forward. I appreciate that article. I think that part of the reason is that we study race as though there are inadequacies in some communities. And I think that's the problem, right? We need to completely reconceptualize this race variable. And we need to understand it as an indication of injustice, not as a kind of this biological construct where we blame everything on physical characteristics. So I think That's my terrible answer to your wonderful question. And I'm hoping that my colleagues can also contribute.
Yes. Well, thank you, Mo. This has been an incredible conversation, and I'm really glad that we had the opportunity to do this. I think in terms of the article, what's really important to remember is that a scientist will naturally look for either biological, that includes genetic, immunology. They're going to naturally look for associations in terms of disease risk. Now, the one thing that we haven't really done, I think it's a really new exploration, is to actually look at what Mo touched on and actually discussed. Dr. Mojgan talked about, Sami talked about, that it's connecting, it's making these connections between historical trauma and looking to see how do these historical traumas impact upregulation of these genes, because that could actually be what is happening. That when you have, and not just that, but if you have certain comorbid conditions, such as hypertension, such as diabetes, we know all of these conditions do exist in vulnerable populations. And yes, so it is up to us as scientists to make that, we have to decipher that. We have to really, and help the public understand, where is this coming from? That is this, are we saying that African Americans or Pacific Islanders are just genetically predisposed to this thing, that it's their fault? Absolutely not. I don't think that's really where the conversation needs to be had. And so I think that it really, and this is where the interdisciplinary research is really important, that a geneticist or a basic biologist needs to work with someone in public health. So, or someone who is a cultural anthropologist, or someone who works, so do you see, so that these bridges are really made. And so when the messaging is sent out, it's not sent out as if, oh, it's, it's your race, and that's why. I mean, I actually have heard people say things like that, and I think, no, that's actually not what it is. It's that they've had consistent structural barriers set in front of them that may actually upregulate and change their genetic pathway.
Yeah, and I wonder if, thank you for contributing that. You made me think of Dr. James Jackson, who just recently passed away. And Dr. Jackson did this seminal work where he started to shift the way that we think about race in social science research. He was a social psychologist. He says, and I quote, "Social science research is oftentimes problem focused." He told the Journal of Black Issues in Higher Education in 2001, "The question tends to start from the perspective of asking, what's wrong with Black people? We approach the issues," he says, "from a different perspective. Our question is, given the structural impediments that Black people face, why do they do so well?" So I think that if we shifted our conversations to understanding systemic and structural issues, our research questions would change, our hypotheses would change. And I really encourage you to read Dr. James Jackson's studies. He really changed the study of Black America by kind of shifting these perspectives that we have and our ideas about how to study race. I really encourage that. And I would love to have it would be so cool if we had this interdisciplinary group to actually talk about this and see if we can contribute to the methodological work of our fields. I think that would be so interesting. I see that other people are asking questions to me in the chat. Lisa, are you seeing?
No, I don't see those. Just you, Mo. We have real quick. We have a question from Cindy.
No problem. Good.
I hesitate to go back a step, and I haven't read the article that Ryan referred to, but just saying, and Dr. Boucher may also want to weigh in, but just looking at the genetics and that there can be benefits in genetics. And if you look at different things like sickle cell disease, it was really protective, as most people probably know, for those of both African American but Mediterranean descent and others as well. So it can be beneficial. And so I wouldn't negate the genetics. It's more multifactorial, and it can be a plus or a minus depending on one's environment and such. So I would say it could be a benefit, and other things like just looking at opioids or codeine, and different racial groups metabolize codeine differently. It's not better or worse, it's different. And so we need to take those type of things into account. So I hesitate to go back down a genetic structural rabbit hole when, to focus the discussion broader about the multifactorial factors that go into the issues. So.
Thank you, Cindy. I've had some questions in my chat privately asking for resources to where to go to study this. I think that I'm so grateful that Cal State is providing an opportunity for all students to study ethnic studies. And I think it sits there. Like so much of the work that we do in research and critical studies sits in ethnic studies, it sits in feminist studies, women's studies, it sits in African American studies, this kind of critical studies that we need to all engage in. And I wish there was more of that in our sciences, right? I wish that there was more critical studies. And because when you shift your conceptualization of everything, whether it's history or your understanding of where these categories come from, it can really shift the way that we engage in the world and with each other. So those of you who are asking me for resources, really do engage in finding things outside of your discipline. It helps so much. So sorry, Lisa, you're moderating and I took over.
No, definitely. Hold on. Archno, I think you probably wanted to comment, right?
Oh, I mean, I want to give the platform to, we have lots of people here.
Okay.
I did have a comment, but I also had a question for Dr. Sami. I think it is so interesting that looking at obviously the genetics and metabolomics, and generally most basic biologists will look at a SNP. They'll look at certain types of single nucleotide polymorphisms and say that whether it's recessive or dominant in this particular group. But I think what they're starting to do now, which is really great, is actually looking at what actually indeed is upregulating these genes. So I think that looking at that, and then if we can connect some of what we talked about today with that upregulation, will really show, and hopefully, as I was saying, make that link between these two very different fields of study. But to that was my question is, what do you think, it's a broad question that it seems that people today still are not quite understanding this, that maybe 10, 20% today on the call are not really recognizing the structural racism that's in place, or maybe even the historical trauma that's in place. So what do you think could be the steps? What do you think is the kind of the road forward in that way? I hope that makes sense.
Yeah, I mean, the more that we understand the fullness of the historical context, the more that we engage in challenging our own habits of thought. It's a real thing for people who have never considered themselves equal, like they don't think of that. It's a real thing to be challenged there, because the reaction to that is, oh, I'm being oppressed. No, nobody's oppressing you. You have had privilege for all this time. All we're saying is everyone else needs the same privilege. So there's a part of it is living through this time with humility and the ability to challenge your own habits of thought, and it goes deeper. It's much less about being nice to your 3 Black friends than it is about challenging your 30 melanin deficient friends and helping them understand why we're going through this. Because often in the world, when we experience difficulty, it's always the vulnerable that can explain it. It's always the ones who have historically been the recipients of that discrimination that can explain it. And what's fascinating, Archana, when you were talking about like the biological expression or the study, I always think we forget that that happens in a context. Everything happens in context. And the more we can understand the context, whether it's history, whether it's social construct of these assumptions that we created 600 years ago that are continuing to build our world today, it's whatever that you can add to that knowledge for yourself to do your work, whether it's biology or physics or economics, it helps change your own insight into what you're studying and the questions that emerge. It's tough. Like I think in the world outside of academia, something that we can engage in is these conversations at the personal level. Like have a conversation about what's happening out there. Not in terms of blaming, but having the conversation of what is our own framework? What are we being challenged by? What is it that we need to understand? This is the first time in my life where I've defended science as much as I've critiqued science. I never imagined that my critique of science would come to the point of actually trying to reverse science denial. It's like, yeah, I want us to shift our thinking about science, but not go back 600 years ago with superstition and ignorance. I need you all to understand this basic science so that I can continue to challenge it in the critical context. So this is kind of my challenge today, is how do I both engage in the scientific discourses and move them out of their decontextualized reality. Sorry, somebody had their hand up, I think, Dr. Lopez.
No, we got all of those. Do you have any more questions that you got?
Oh. Thank you, everybody, for like reaching out and like talking. I think it's hard when all these people are here, but I love it. So keep talking. Ryan, do you have more to add? My former student at UCI, who's now getting his own doctorate, it makes me so happy to see. There was a question, I answered that one. Somebody asked, how do you see racial justice and healthcare align? So as you know, Dr. King talks about the greatest injustice that exists is the one in health, because healthcare, so systems, hospital systems themselves, and the medical system that is framed through this lens of Western modern science assumptions. Like let's take mental health, for example. I think we often hear the phrase, there is stigma, mental health stigma in communities of color. But when you deeply dive into mental and spiritual health conceptualizations in Indigenous, Africana, Islamic, basically non-European and American constructs, you understand that mental health is not divorced from the community. Mental health is not divorced from spirituality. So it's not so much that there's a stigma to mental health care, but there is a distrust of this kind of clinical white coat care that maybe communities of color have suffered from in the past, like the Tuskegee trials in 1932. So there has to be some trust building that's needed. And I think part of that is developing cultural humility, and that goes beyond cultural competency. I think in nursing, we study compassionate care, and I think we need more of that in healthcare itself, and the ability to incorporate frames of understanding and worldviews that are not solely through this kind of modern biomedical lens, because that's going to help us achieve a better result with the actual care that happens in the clinic. That's kind of my first take. But I have wonderful nurses here who are so much more expert in this than me. So I would love your contribution to this conversation as well.
Any more? We have a few more minutes to ask another question or comment. Thank you all. This has been great.
Everyone. I'm just looking at your lovely faces. I'm wondering if Dr. Rhodes would like to say anything. Sorry, Dr. Rhodes, I'm calling you out. Dean Rhodes. Oh, she's muted.
Hold on. We'll get her unmuted. There you go.
I can't even believe they let me talk. So this is wonderful. No, I'm just grateful that you shared your expertise. I messaged you privately. You probably saw it. I just wanted to thank you for sharing your expertise. Part of what we want to do is have discussions, which involve both the opportunity to share what you know, but also allow us to think about things more broadly. And I appreciate our colleagues' discussion of ways we can collaborate not only within our college, but across colleges, because the large questions that our faculty colleagues and our experts seek to answer really are ones that will require that transdisciplinary perspective. And so we really do want to make sure that folks know that in our college, we welcome that kind of collaboration and that kind of working together. And I thank you for kicking it off for us this year.
Thank you, Dean Rhodes. I'm really looking forward to seeing these conversations grow, because I think sometimes people don't understand that public health is ultimately about social justice. And I think, at the end of it, public health and urban planning developed simultaneously in the 1800s within the context of Europe and the United States when there was a need for sanitation reform. So these disciplines emerged together mostly as a way to bridge this injustice that happened in cities, like trying to solve the problems of the city. And although we haven't addressed all the problems in the city, and more have been added because of our awareness, I think it brings us to the understanding that everything has to be contextualized. And we have to understand the historical contexts, and thinking more deliberately and consciously about the conceptualizations that we have about the world that we want to live in, about what health means, particularly in this day and age where we're struggling with the dual pandemics of COVID-19 and racism and the emerging climate change disaster that's coming. So that's here already. So as we do this kind of hopefully together in these conversations, I'm looking forward to more deep collaboration with colleagues.
We have one quick question before I get started. A challenge I've seen is that science is being decontextualized, editorialized, and used in media to send the public to polarized, incomplete views. How do you get true data that is also contextualized in front of the public?
That's my question too. Let's work together to figure that out. I feel like that's also something I think about a lot. And how are people internalizing the data, right? I think that is also, there's an interpretation and a communication of it. Everything that you're hearing in terms of communication around COVID is kind of risk communication 101. Don't do this, don't do that. Everything you're seeing is kind of don't do this. And unfortunately, we haven't allowed the risk communication specialists to kind of lead the effort. I think we would be in a really different place if we had. I think that's part of it. But everyone talks about STEM, and we forget that there's STEAM. We have to include the social sciences for students who are studying science, because otherwise everything is so decontextualized, then it makes it really hard for scientists to translate data for the general public. So we tend to talk in our echo chambers. So we need so much more work together to be able to translate science to action on the ground. And that includes, for me, including communities in these conversations and inviting and honoring back in ontologies and epistemologies that are not just framed through American and European colonial gaze, but also opening up and honoring, again, the Africana Islamic indigenous systems of knowledge. Like, we have to be able to bring that back into the discourse so that our communities, we can also help build trust and collaboration. So thank you.
Any closing comments, Mo? We're a couple minutes.
I think that was it.
That was it. Thank you all again for joining us.
Thank you.
We really appreciate taking the time, you taking the time to join us for our critical conversations on health equity lunch and learn. Please keep a lookout for future conversations and lunch and learns we're going to have. And we thank you all. And everyone have a really pleasant day.
Thank you. Thank you all my friends who joined. Thank you.
Goodbye.
Bye.